Welcome, everyone, and thank you for joining us for today's session, Frequently Asked Questions on BCMA-Targeted Bispecific Antibody Therapy. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I'm joined by Dr. Saad Usmani and Ms. Anna Howard from the Memorial Sloan Kettering Cancer Center in New York City. They're here to answer your questions about this latest multiple myeloma therapy option. So my first question is for you, Dr. Usmani. Thank you again for taking the time to be with us today. So what is the difference between a bispecific antibody and other antibodies like Darzalex or Sarclisa?
Thank you so much, Mary, for having me here in this, live discussion. Let me start by explaining, these different technologies. So antibodies like, daratumumab and elotuzumab are what we call monoclonal naked antibodies. So they target a specific protein on the surface of myeloma cells, and they rely on the usual immune-mediated mechanisms to kill the myeloma cells. Whereas the bispecific antibodies are a little different. One part of the antibody can recognize the surface protein on the cancer cell, and the other part recognizes the surface marker on an immune cell like T cell. So the bispecific antibodies bring the patient's immune cell, which could be a T cell, or we're also looking at some NK cell bispecifics now in clinical trials. But the idea is you bring the patient's immune cell to the cancer cell and help kill it. So it's a very unique modality, and it is showing extremely good results in several cancers, including multiple myeloma.
Great, perfect, thank you. So Anna, next question is for you. So thank you for being with us today. So we use the phrase off the shelf a lot when referring to bispecific antibodies, especially when comparing them to, say, for example, a CAR T cell therapy. So can you explain to us what off the shelf means?
Yes, well, thank you for having me as well, Mary. So off the shelf means that the bispecific antibodies don't have to be tailor-made to each patient. So especially when you compare that to something like CAR T cells, where the T cells have to be collected and then manufactured for each patient specifically. And that process, it varies how long it takes, but that process can even take a month, sometimes more, sometimes less. Whereas with the bispecific antibodies, what we have in stock is what we're giving to all the patients. So that's what we mean when we say off the shelf.
Mm-hmm. Great, thank you. So Dr. Usmani, patients are usually surprised that bispecific antibody therapy is given as a single agent, because most of the time, as you know, people are taking combinations of therapies, but this is really just a single agent therapy, similar to CAR T, but different. So can you clarify what single agent means and what makes bispecific antibodies so different from other myeloma drugs that are given in combination?
Yes, certainly. So, before the bispecifics and CAR Ts were developed in multiple myeloma, the usual activity of single agent treatment means one drug, you're just getting one drug. All the other treatments that we had evaluated in clinical trials that led to the approval in the relapse refractory space, drugs such as carfilzomib, pomalidomide, bortezomib, lenalidomide, even daratumumab, they were used as single agents, and their activity, was somewhere in the 20 to 30% range. That means that if we treat, 10 patients, 2 to 3 would have a good response to treatment. And so with that in mind, once those drugs showed that activity, we started to combine them together so that we can, get higher levels of activity. What was amazing to see with CAR T cells and bispecifics, on its own, these therapies can give very high response rates. So the bispecific antibodies can give a response rate of 60 to 70%. And that is quite remarkable. So based on the remarkable results, the bispecific antibody, teclistamab was FDA approved as well as approved in Europe last year. as a single agent for more advanced myeloma patients, relapsed refractory patients, because of that reason.
So, Dr. Usmani, considering the important role that T cells play in the effectiveness of bispecific antibodies, do patients have to be screened for the numbers of T cells or the activity of their T cells prior to receiving a bispecific antibody therapy?
That's a very good question. So typically we do not, and in fact, in all the early clinical trials, this is not something that we've really done. We know that when myeloma is diagnosed, many times the T cells are already dysfunctional, and that dysfunction, kind of stays, or it may actually, increase over time as patients receive treatment for several lines of treatment. So the fact that even in more advanced relapsed refractory myeloma patients who've had 5 or more prior lines of treatment, we are seeing 60 to 70% responses, tells us that, we need some level of T cell activity. But, the challenge for us as, scientists and clinicians has been defining what that number or that activity level is. So that's actually something that we're actually studying right now to understand it better. I hope that makes sense.
No, it does. It makes total sense. So Anna, what are the main similarities and differences in the patient experience between receiving an antibody therapy like Darzalex or Sarclisa and receiving a bispecific antibody therapy like Tecvayli? Specifically, talking about infusion or injection times, need for hospitalization, need for pre-medications, or need for a caregiver, et cetera. What can you tell us?
Yeah, so I'll start with the main difference with the teclistamab or the bispecific antibodies compared to the other medications that you mentioned would be the need for hospitalization. So there are some specific toxicities that we're concerned about with medications like teclistamab, which we'll talk more about those toxicities, I think, later in the discussion. But because of the concern for those toxicities that are most likely to happen in the initial doses, we administer it through step-up dosing, meaning that you get a small dose, a medium dose, and then the final full dose of the medication. And that process has to take place inpatient in the hospital so that you can be closely monitored for those toxicities. So I usually tell my patients to plan for about a week admitted in the hospital while they do the step-up dosing. It can be a little bit less or sometimes more if there's complications. So that's probably the biggest difference with the teclistamab versus something like the daratumumab. But once they receive that full dose, then the patients receive the rest of the injections in the outpatient setting. So similar to the daratumumab, it's a once weekly injection. It's given subcutaneously in the fatty part of the stomach. And I think you also asked about pre-meds. With that, we typically will give pre-meds for the step-up dosing, similar to with other treatments like Benadryl or steroids like dexamethasone. But once they're outpatient, we typically don't do pre-meds for patients. And then in terms of caregiver needs as well, there's no restrictions about patients being able to drive to and from their outpatient appointments when they're receiving the teclistamab. So they don't have to have a caregiver come with them if they're not able to.
Okay. So, Dr. Usmani, so Tecvayli is the first bispecific that's been approved in myeloma, and it specifically binds to B-cell maturation antigen, or BCMA, on the myeloma cell. So can you talk to us about what BCMA is and why it's a good target for antibodies, and why not just use a target like CD38, which is also on myeloma cells?
So, BCMA is an acronym for B-cell maturation antigen. And B-cell maturation antigen is a protein or surface marker that is present or expressed on mature B cells as well as plasma cells. And it's an important surface marker or protein for maturation as well as growth and differentiation of plasma cells. So it's a good marker because it is kind of unique to just the mature B cells and plasma cells, and we do not anticipate a lot of off-target effects with treatment. So the safety or side effect profile would be better with that particular target.
Mm-hmm. So, and as a follow-up to that question, so if BCMA is found on all plasma cells, so myeloma cells, which are the cancerous plasma cells, and then also the non-cancerous plasma cells. So if you're targeting BCMA with this bispecific antibody, would that prevent a patient from producing other normal antibodies while on this form of therapy?
So technically, yes, and that's, one of the reasons why, when we treat patients with teclistamab or other BCMA-directed bispecific treatments, or even with CAR T-cell therapy, we have to be watchful for risk of infections.
Mm-hmm.
Many times we see that patients start developing low total immunoglobulin levels, or what we call hypogammaglobulinemia, and they might require IVIG replacement, in that case. And then because the immune system can be affected, we sometimes put patients on prophylactic antiviral or antimicrobial coverage as well. This is something that we see with both CARs and bispecifics, but the difference here is with bispecifics, right now we continue treatment, until patients continue to tolerate it and the disease stays under control. So what we're trying to figure out now, because of this, infection risk issue, is, other ways in which we can dose or schedule these therapies to reduce that risk of infection.
Mm-hmm, mm-hmm. Yeah, I know it's a very serious matter with bispecifics, and we talk about that a lot at some of the scientific meetings. So it's becoming more and more of an issue. So Anna, which patients are able to receive BCMA-targeted bispecific antibodies like Tecvayli? And how easy or difficult is it for patients to get access to that therapy?
Yeah, so the Tecvayli or teclistamab was just FDA approved at the end of 2022. So the current FDA approval is for patients that have had 4 or more prior lines of therapy, meaning that they've progressed through 4 different lines of treatment. And there's some specifications about medications that they had to have received prior. In terms of access for patients, how we talked about a little bit at the beginning, the fact that it is off the shelf does make it a little bit easier to access for patients. One of the kind of barriers, or it does depend on where patients are, because hospitals have to be enrolled in the a REMS program for the teclistamab. So they have to have certain certifications and training to be able to administer it in the inpatient setting. So not all of the hospitals right by patients have been enrolled in that yet. So that's definitely a barrier for access right now for patients. But it is an option for patients to go to hospitals that are enrolled in the REMS program, receive the teclistamab there for their inpatient step-up dosing, and then return to their regular local outpatient setting to receive the rest of the weekly doses. So that's that we've done for patients at MSK as well. So that helps to broaden the access to more patients.
Right. And is there any kind of an age limit for patients receiving a bispecific antibody treatment?
Yeah, so there's no specific strict age limit or upper age limit for these therapies. With every treatment, we obviously assess each patient individually and assess their functional status and see if the treatment would be appropriate for them.
Great, thank you. So Dr. Usmani, can you tell us why patients have to go through multiple relapses before they can get bispecific antibody therapy? And does the success rate of this type of therapy decrease if a patient is heavily pretreated and their immune system is already weakened more than it would be like in an earlier course of the disease?
The way that we develop new therapies in clinical trials is, especially if it's a new treatment that's coming into clinical trials, is to see if it will work in patients who have had their disease progress or not respond to other treatments that are already available to us. And so that's kind of how clinical drug development works, and we need to make sure that the treatment is safe as well as effective for our patients before we move to the frontline treatment. So right now, teclistamab is currently approved for 4 or more prior lines of treatment, because the clinical trial that led to its approval, included only those patients. In terms of activity, it's quite active. The response rate on the clinical trial was, as I previously mentioned, it was 63%. So it is quite active, even though patients have had other treatments in the past. The next logical question is, will it be better active in earlier lines of treatment? I think we are looking for that answer right now in clinical trials, and hopefully we'll have that, in the next few years for our patients.
Yeah, it's sort of really interesting to see some of these therapies move to earlier lines. And also, there's some interesting studies ongoing with Tecvayli in combination with other therapies, which really seems to actually increase its already impressive activity. So we'll see how all that stuff comes out. Anna, how are patients followed in the clinic after they've received Tecvayli?
Yeah, so as I kind of mentioned earlier, they continue to get, at this point, weekly subcutaneous injections of the Tecvayli. And with each of those injections, we monitor their labs, so like a basic metabolic panel, a complete blood count, and then we see patients monthly in clinic. So it's once a cycle that we see them.
Okay. So, Dr. Usmani, is a BCMA-targeted bispecific antibody like Tecvayli effective in a patient who's previously received and relapsed from another BCMA-targeted therapy like CAR-T, Abecma or Carvykti? This sequencing is such a big topic of conversation right now with some of these BCMA-targeted therapies. What can you tell us?
So there is very limited data, that's out in the public domain. We have done studies where prior BCMA exposed patients have been given, teclistamab, and what we find is the patients do respond. About half of the patients. So we have 50% responses reported in one of the cohorts in clinical trials. But one thing we don't know is how long will that activity last.
Right.
My general sense is if someone had a BCMA-directed CAR-T cell therapy, more than 6 months ago, and the disease is making a comeback, myeloma cells don't lose BCMA. So, for the most part, most people, in fact, vast majority of patients, that's not the mechanism of how, the disease becomes resistant to a BCMA treatment. So, you can still give a BCMA bispecific to those patients. And, we are actually looking at this very actively in our commercial drug use. And, one of our, my fellows, Dr. Firestone will be presenting, this information at the upcoming ASCO meeting as well.
Excellent. Good. I look forward to seeing that presentation. Great. So, Anna, we're going to talk now about side effects of treatment, which we've sort of touched on already. So it seems like myeloma therapies that involve activating a patient's T cells, like bispecific antibodies and CAR T cells, are associated with a unique set of side effects that we haven't observed with some of the other therapies that patients are given. So when you prepare a patient to receive Tecvayli, what do you explain to them that they should be aware of for side effects and what they might experience?
Yeah, so one of the biggest things that we educate patients on prior to them receiving the Tecvayli is the risk of cytokine release syndrome, or CRS, which is basically an inflammatory reaction that can occur as the T cells are activated by the medication. And so some side effects that are what can kind of how it manifests is you can have fevers, headaches, low blood pressure, difficulty breathing. And so this is kind of one of the main reasons that we have patients admitted in the hospital at that step-up dosing, because the highest risk of CRS is during that initial dosing and the step-up dosing. So, it's good that patients are in the hospital for this because they can be very closely monitored for these effects and managed with the resources that the hospital has. So that's the biggest thing that we want to make sure patients are aware of going into their admission. And then, continuing to monitor for those symptoms when they're outpatient, as well as some symptoms that we see with some of the other treatments like GI distress, bone pain is a common side effect as well that we see with these patients.
Interesting. So, Dr. Usmani, neurotoxicity is another side effect that's associated with bispecific antibody treatment. So is that type of neurotoxicity similar or different than the type of neurotoxicity that patients experience with Velcade? And are the bispecific antibody-related neurotoxicities permanent, or do they fade over time after treatment is completed?
Yeah, so, neurotoxicity is a very broad term, and with CAR T cell therapies, we have this condition called ICANS, where patients can have, more pronounced, symptoms of altered mental status, and even seizures, if it's high grade. With bispecifics, we don't see those kind of side effects. And in fact, the most common, neurotoxicity is just headaches, and which are treated with, Tylenol, etc. But, we can see, sometimes, some, confusion in some patients. It happens very rarely. It's, kind of transient, and very rarely, peripheral neuropathy, has been reported, which is again transient,
Really?
and it gets better. It's very different from, the kind of neurologic side effects that you would observe with bortezomib, where you get, tingling and numbness because the drug is affecting the nerves directly. And it really has to do with, BCMA being expressed in certain organs, at a very low level, and the bispecific antibody and the T cells can kind of act, on those organs. But neurotoxicity, for the most part, it's not a big concern for bispecific administration compared to CAR T cells.
Okay. So, Anna, if a patient experiences any of these toxicities that we've been discussing, so how are these toxicities managed in the clinic?
Yeah, so it depends a little bit on the severity of some of these toxicities, especially if anything occurs, especially in the step-up dosing, we'll typically wait to give the next dose until the symptoms have resolved. For more mild symptoms, we manage, Dr. Usmani mentioned, with Tylenol. They can give IV fluids as well, just supportive care to help manage them. And then while they're inpatient, if they were to have more significant CRS, there's a medication called Toci that we give that helps calm the immune system down. And then for like peripheral neuropathy, there's some patients that need gabapentin to help with that, or other medications similar to that. And then, as well as Dr. Usmani mentioned earlier, where we're looking at spacing out the doses a little bit more for patients that are especially experiencing some of these side effects and toxicities.
Great. Okay, so Dr. Usmani, we're going to go back a little bit to infection risk. So we already talked about that a little bit. So this is high for patients on bispecifics. So is the infection risk that patients on bispecifics experience similar to that they've experienced when they had a stem cell transplant? And is the patient's immunity impaired for as long as they're taking the bispecific antibody? And is the impairment reversible once they're off treatment?
Yeah, so one very important thing to understand is that, almost all patients, who have had 4 or 5 lines of treatment, they are going to be immune compromised and inherently be at risk for infection. So that's number one. And then, with the bispecifics, once we discontinue the treatment, that baseline risk doesn't go away. But, the general risk of infection attributed to the bispecific, that does get better. So, for example, with bispecifics, we are seeing sometimes, viral infection reactivations, with uncommon, infections like, CMV or EBV. That kind of risk goes down. But if someone was at a higher chance of getting chest infections or respiratory infections, that risk, because of having myeloma and being immunocompromised, doesn't go away.
So also, Anna, patients have heard that some bispecifics can affect a patient's sense of taste or their smell. So can you clarify if this is general to all bispecifics or only to some of the drugs in that class?
Yeah, so the changes to the taste and smell is something that we are still kind of learning about. It's more of a rare and unusual side effect that we don't see that commonly with these bispecifics. So we're still kind of trying to get information on it, actually. And one of the things is trying to figure out exactly what is causing those changes to then help better manage them as well.
Yeah, okay, that makes sense. Okay, so we just like ran through all these questions like pretty quickly. So I just have the final question for you, Dr. Usmani. Can patients expect any more bispecific antibodies to become approved and available? And if so, when do you think that's going to happen? Look into your crystal ball.
No, I don't have to look into the crystal ball because we have over a dozen different bispecifics in clinical trials right now.
There are a lot. There's a lot
at various phases of development, and it's not just the BCMA-directed bispecifics. We also have GPRC5D, which is another surface marker on myeloma cells. There is another protein called FCRH5. So there are bispecific antibodies targeting, not just BCMA, but these others. So, if I look at my crystal ball, I would say that, maybe in a year from now, we might have, one or two more bispecifics that get approved. And then, it will be only a matter of time that others start, getting approved. I have to say, from a, so this is, measured hope for all of our patients, for sure. But, and I'm using the word measured hope because, getting the drugs approved, through the FDA, the benchmarks continue to change, we're saying right now that, yes, we expect these drugs to, to come out in the market a year from now, but, that may change depending on some of, how FDA looks at this data.
Great. Okay, so I think that in general, this is a really exciting new class of therapies and patients are really very interested. So I'd like to thank both of you for being with us today and answering all of these questions. I'd like to thank everybody who's watching for taking time out of their day to watch this session. And I also, go ahead.
No, I was going to say, maybe we can take a look if there are any questions coming in.
Actually, we do have a little time, huh? Yeah, so we do have a little time. Okay,
so maybe we can take, a couple of those questions.
Yeah. Actually, we only have two. So, okay, so here's the first one. Are there any patients for whom bispecific antibodies are not an option? And what conditions, if any, would rule out this therapy?
Yeah, I don't think there are any contraindications, there are any specific contraindications. The only thing that I would worry about is performance status and frailty. And if I'm concerned, that patients may not be able to, withstand the CRS risk or infection risk, and they're frail, that would be the only situation. But, we've treated patients with bispecifics who are in their 80s, who've tolerated treatment very well and responded well. Yeah.
That's great. Okay, so here's another question. I'm not even sure what this person is asking, but do patients need a certain LVEF level to tolerate the CRS of bispecifics, and does the target matter? I don't even know what LVEF is. What is that?
So that is heart function. So
okay.
So my response is
like your ejection fraction or whatever, right?
Exactly. So it's left ventricular ejection fraction.
Right.
So there is no cutoff for that for bispecifics. Maybe for CAR T cell therapies, and this is where we can distinguish using one versus the other. And the use of does the target matter? We do feel that the target matters right now. BCMA is the one that's been studied the most. For some of these targets, like I mentioned, BCMA doesn't get mutated or lost very commonly when myeloma progresses. So you can potentially use different BCMA treatments for patients and sequence them. We're just learning that that's probably not the case for GPRC5D. That GPRC5D can get lost and it doesn't recover. So so sequencing will become a very interesting topic over the next 2-3 years as more of these
Yes.
treatments become available to us.
Yes, definitely.
All right.
So those are the 2 questions we've got. So now we answered them. So now we're really done. Okay, so. All right. So again, thank you, Dr. Usmani, for being with us. Thank you, Anna, for being with us. Thanks, everybody, for watching. And we're going to send everybody who's watching out a brief evaluation form at the end of the session. So we'd appreciate that if you would fill that out for us. Finally, I'd like to thank our sponsors, Janssen and Regeneron. And if you have additional questions about what you've heard today, don't hesitate to call our MMRF Patient Navigation Center at 1-888-841-6673. Thank you and have a great rest of your day.